got a presentation that we're going to put up. So, hi everyone. So I'm Debs. I'm a consultant at Bart's Hospital. And we've got Martin, who's also a cardiothoracic surgeon and consultant at Bart's. Gary McAllister is the Chief Technology Officer for London, and Kathy, Transformation Lead at Guy's and St Thomas's. What we're going to be talking about is a pan-London deployment of remote monitoring and a virtual ward for a specific use case, and specifically talk about our journey from procurement, from deciding to do it, getting minds together, procurement, the process involved in actually deploying, and some of what have we shown for our results. So Martin is going to do a brief presentation of giving a summary, and then we'll have a kind of a chat about what we've learned so far. Over to you.
Great, thank you very much, Debs. Thank you very much for having us here this morning. My name is Martin Yates. I'm a consulting cardiac surgeon at St Bartholomew's Hospital here in London, and I'm representing the whole team across London. Hi, better? I'm representing the whole team across London, so thank you for having us. What we'd like to do is just discuss a little bit about what we've been doing in the last 18 months in cardiac surgery and cardiology across London, and how we've got an integrated approach to developing remote monitoring. So the background to this really came from COVID, of course. There's 7 cardiac surgery centres that provide heart surgery for all of London and the surrounding area. And of course, during COVID, we were extremely limited in what we're able to provide the patients due to limited capacity in intensive care beds. In order to allow equity of access for all patients across the region to access heart surgery in a priority required, it involved all of the centres getting together, and a coordination really led by Harefield Hospital in the west of London and Bart's Hospital here in the city to make sure that patients, no matter where they lived across the region, could still access heart surgery. Now, the legacy of COVID, of course, was that there's an increased number of patients waiting for elective heart surgery, and the waiting times for surgery is longer than it was previously. And therefore, it became essential that we had a way of not only monitoring patients who are at home waiting for surgery, but also reprioritising on almost a real-time basis of who needs surgery at the highest priority and where that should be carried out. So around 18 months ago, we started trying to find a solution to this big problem. And the solution was to get all of the heart surgery and cardiology centres together in London with supporting partners that could help us find a solution to monitoring these patients. And we put in a bid to NHSX to help us find this solution. And we were one of the 2 networks in the country that won the bid to find this solution. So this happened about a year ago now, and then we went to an independent procurement process, and that process reviewed all of the remote digital monitoring tools for patients to see which was the most suitable, and we'll talk a little bit more depth about that later of how we came to choosing Ortus as our chosen partner. We've since then, in the last couple of months, rolled this out across London, and we'll discuss a little bit about how we did that and the results that we're seeing so far. So as I said, the main aim for this was to find a way to keep patients safe who are waiting for cardiac surgery at home and prioritise them based on their clinical need, not particularly on when they went on the waiting list or which part of London that they live in. The only way to do this was for all the centres to work together, and this is not a normal process. Usually each cardiac surgery centre works alone, but because of what we learned in COVID, we all knew each other and we're all able to work together, and therefore we have a unified operating protocol across London that means that all the patients are having the same care no matter where they live. Additional things that we're able to offer once patients are in this pathway are things like digital consent or e-consent, asynchronous messaging from the patients when they're at home and even if they're not coming to the clinic, and then health information, rehabilitation after their surgery. So the platform that was chosen through our procurement process for this pathway was the Ortus platform. This is a remote digital monitoring platform that's web-based or app-based. The patients are recruited onto this, and through this they can do all of these functions, some of which we're using more often than others, with varying benefits. The patients can interact with us both by video and by text, and they fill in questionnaires. We can see results of blood tests, heart rates and blood pressure that they're measuring, and any tests that they have at home. Patients are then put onto what we call a virtual ward. So we have everyone who's on the waiting list in London for cardiac surgery at the moment are in a virtual ward being monitored by different teams. On a weekly basis, the patients are filling in questionnaires about their symptoms, which are then compared to what their symptoms were last week and the week before. And they're also able to fill in physiological measurements like how many steps they're doing in their activity, their heart rate, their blood pressure, their oxygen saturations. And the platform's able to then flag up things that are of concern that are then triaged by health professionals who then contact the patient should there be any issues. The additional benefits of having patients on these virtual platforms is that then you can give them other information about their conditions, other information about things that we want them to do in order to keep themselves safe before an operation or to have rehabilitation after their operation. So this is what we've done across London. There are 7 hospitals providing cardiac surgery and 1 other large tertiary centre providing advanced cardiology. Over the last 2 months, the first hospital to come on board was the Brompton and Harefield Hospital in West London. And since then, St Bartholomew's Hospital have come on board, with Guy's and Tommy's joining as well. The 2 hospitals that are still to come on board actually have the smallest waiting list, so only a small fraction of patients that are about to join. And shortly we'll have every patient who's in London waiting for heart surgery on this platform. This is a quick synopsis of what we've achieved in the last 2 months. So these are the 4 main hospitals that are recruiting patients. And we can see that now over 1,000 patients have been onboarded onto this platform. And that represents almost all patients waiting for surgery across London. We can see that we've got a very high activation rate for patients that are interacting with the platform. So more than 3/4 of the patients who have been offered this ability have taken it up and are now interacting with us on a weekly basis. And we can discuss perhaps in the discussion about why that might be, because this is a high uptake for these digital platforms. And I think that's because the patients are highly motivated in order to get their operation. And already in those first 2 months, we've had 45 patients who've benefited by having the remote monitoring signal a deterioration in their condition or an increase in symptoms. And when we've reviewed them, those have been genuine deteriorations that we've then organised for patients to come into the hospital sooner than they ordinarily would, have now had their heart surgery and have gone home. So we're already seeing very quickly that this remote digital solution across all of the hospitals offering cardiac surgery in London is giving benefit to real patients. Thank you very much.
So what I thought we'd talk about first was about the process of, 8 tertiary cardiac centres coming together. As you can imagine, the names that we showed, we all often think we're the best tertiary cardiac centre. But getting us to all work together in this way actually is as novel as the pathway that we are delivering. So, Martin, can you tell me a bit more about the cardiac networks and how did they decide to put together this bid and decide what they wanted to do?
Yeah, of course. So I alluded to this a little bit in the presentation, is that this really has all come about during COVID. So historically, cardiac surgery is offered in different hospitals, and often even within a hospital, individual surgeons will maintain their own waiting list. So as you can imagine, there's a disparity in what the patients are offered, depending on which hospital you are going to and which surgeon's waiting list you're on. There can be big variations in that. When COVID hit, we realised that there was big inequity of access to patients being able to access cardiac surgery purely because of where they lived across London. And everyone agreed that that wasn't fair and wasn't right, and that the patients should be prioritised on their clinical state rather than anything else. So as soon as everyone realised that, the surgeon's main priority, of course, is the patient. And even though we're very comfortable with the historical way that we did this, it had to change. And when we saw how well it worked and the service the patients got during COVID, that's why we were able to, in the legacy of COVID, come together and get the team together, who we'd all worked very closely during that time, to come together to do this. So I think everyone very quickly realised this was the right thing to do. It, of course, was a lot of work getting all of the right partners who could tell us the best way to go about doing it, and then we can maybe talk about how we did that.
Great. And even so, just for some more context, cardiology across England now has realised that we should work together in groups of networks. So groups of hospitals together form cardiac networks. We've also realised that cardiologists don't work in silos, but also work with our cardiac surgeons. So there's no longer that divide between the cardiac surgeon and the cardiologist. We understand that that patient is part of that same continuum. So in London, we have two networks, the North London network and the South London network, who got together and decided this procurement process. For full conflicts of interest, the solution that was chosen was one that I had built with help at Bart's Hospital and had been live there. But one thing I did notice when the procurement came out was that the requirements was very robust. And I think, Kathy, you're at the heart of making that requirement list. It'd be good to understand the journey Harefield Hospital went through before and then came to kind of knowing what you needed, because we know lots of ICSs at the moment will be going through understanding from the virtual ward needs what they require. So, Kathy?
Yeah, so we began working, looking at a solution for our virtual wards and our remote monitoring back at the beginning of COVID, when we realised that we weren't able to operate on these patients when we wanted to, and that we needed to find a way to make sure that these patients were safe. We began working with another company, and we took information from our patients and from our staff, and we were able to build and design and to know exactly what we wanted from the solution. We wanted to be able to send our patients messages. We wanted to be able to receive those messages back from them. And patients wanted to be able, they told us that they wanted to be able to access the app, not just on an app, but on a browser. So we knew exactly what we needed, and that's you know, it drove our spec. It gave us a very clear wish list of what we needed to be able to deliver for our patients and for our staff.
Thank you. And Gary, you were involved as well, kind of setting what were the expectations from the provider as well. I know often the remote monitoring space is a new space for ICSs. Understanding the technicalities, the interoperability, what a provider should also be kind of committing to. How did we go about doing that process?
Yeah, so I think one of the things about clinical networks is what we're seeing is it's a drive towards disease-specific or pathway-specific service provision now. So these big like EPR systems that we've been used to working within before don't tend to cross boundaries very well. And one of the things that we found through the procurement process is that the Autos system itself is very configurable, and that was one of the requirements. It was making sure that when we ended up with a product, it was something that could be tailored not just to cardiac services, but equally to any other pathway-orientated disease or illness. So in London, I have the pleasure of working across many networks: diabetes, stroke, and the other kind of usual suspects, long-term conditions. And what we want to do as we move forwards is be able to leverage the benefits of the procurement that we went through for cardiac for other services, so that we're not adding yet more IT onto our organisations, increasing like cost of ownership. But equally, it's vital that these systems do talk to providers as well. So we talked a bit about interoperability. You know, there are standards out there that we expect these systems to meet. We really want them to be modern, and we want them to be open, and that data not to be locked away, because it needs to be used for secondary use and for research and for other vital analytical purposes. So fundamental to the specification process is making sure that it cross-applies and that we can use the system itself for other purposes, and the standards are followed. And also that it's secure. So we had some pretty strict needs that we were lucky to receive at the end.
Great. So, I mean, once the solution was procured, we had the mammoth task of actually deploying at pace across 8 cardiac centres, and we are close to doing so. Kathy, and also Martin, could you give us your experience of how we've gone about doing that? I'm going to start with Kathy, given that Harefield got there first.
So, yeah, we began with a usual project plan with a roadmap for where we wanted to be, and we began working with Autis in May, maybe a little bit before May. Initially engaging with stakeholders, making a plan for when we wanted to go live. Guy's and St Thomas's now has 3 sites within it, so I was quite clear from the beginning. I wanted to stagger the go live dates so that we could go live on one site and then learn lessons before we went live on the next site. We only staggered it by about a week, but that did really help, I think, and it allowed us to learn lessons quite quickly.
Martin, from a Bart's perspective, did you notice anything?
Yes, I think when we were thinking about rolling this out, one of the things that we were particularly worried about was patients that wouldn't be able to use the platform. And we did quite a lot of work before this to work out that our patients would be able to use it. And it's been very enlightening for me, and I think a lot of my colleagues, that many patients, no matter what their age, are able to access these technologies and use them, in the same way that patients who may be elderly or not speak English as their first language would usually have help. So they'll usually have a son or a daughter or a friend that will come to the hospital with them to our clinics and help understand what's going on. These people can do the same with technology. So we're trying to reduce the number of people that are excluded from these. And I think that's part of the reason that we have such a high uptake, is that we've allowed these extra things to happen so that we're including a whole family, not just the patient.
So, I mean, one of the things I also noticed as a provider coming in was the clinical leadership was there, visible up front, and it really set the tone. I remember the first meeting that we had with Harefield, and we had the medical director sat there saying, "This is what we must do." And that really just set the pace of everything else. Similarly at Bart's, we had strong leadership in delivering this. And actually, once we got that, there was a fear of the missing out from the other centres as well. Healthy competition between Guy's and Bart's, who were going to go first. And again, someone who was in the in-between would slightly exaggerate how far the other team was. So I think when deploying these programs, and I'm sure we've said it before, clinical leadership and buy-in is really, really important, and top down. If you don't have the support of your leaders, it's very difficult on the ground to deliver. So once we have deployed, one of the things that we were very cognizant of, all virtual wards, all remote monitoring, is more work. It's more work for staff. All you're doing is managing people in a different setting, and often managing more people and opening the door. Whenever you have a digital front door, it's a new door for patients to walk through in. So I'll go to Martin and then Kathy. What have you noticed with the increased access for your patients?
So, this is one of the big benefits of this platform, is that one of the issues with the NHS is that it's difficult for patients to access the people they need to access at the time they want to access it. And we're very aware of that, and this is a solution to that. So we knew when we started this that this was going to increase our workload, but in a way that was the right thing for the patients. And when we started, we had no idea how much work this would be. And it was really just a case of starting it and seeing what happened. And what happened was that you and I did a lot of the work to begin with to keep an eye on how much was going to be required. And in terms of the extra workload for us at Barts, monitoring our whole waiting list, it's been a senior nurse for 2 to 3 days a week has been the increased workload up front, with quite a lot of clinical leadership. And going forward, we hope that that workload will reduce as we make our other pathways more efficient now the patients are on the digital platform.
Yeah, I agree. So wherever you've replaced nothing with something, that's going to increase the workload. And that has, I think, been the biggest challenge to plan for and to know how much time this is going to take. The good thing about what you can do with Autis is you can channel the responses to come in on certain days, and that's allowed our clinical teams to manage their workload so that they can almost book themselves into an Autis clinic for a specific day, knowing that those patient responses will come in on certain days of the week rather than all across the 5 days. Patients are telling us that they really like to be able to communicate with clinical teams in a way that they just haven't been able to. And I think 5 years ago, the patient would have seen their consultant surgeon, and they would have put on a list, and they probably would have waited about 2 or 3 weeks to hear from the pre-op team. That is now an unknown wait time, particularly if those patients have been allocated a P3 or a P4. They don't hear from anybody, or they didn't hear from anybody until they were called for their pre-assessment, and now they've got a way of communicating with us, particularly if they have concerns that they are getting worse, and they know that somebody is listening, and that gives the organisation a face and a voice, and it means that they're not stuck in this limbo without anybody to contact.
Yeah, I agree. And a lot of the remote monitoring work that we've been doing at Barts increases the touch points with your patients. That's an important, and we're doing that on purpose. We know that those increased touch points can have better outcomes for patients, be it medicines optimization or patients being able to flag that they're deteriorating. It's how do we manage those increased touch points? We can't, and that's where tech should come into it. You can't have switchboards of people contacting people every single day. We have to have a filter where tech allows you to prioritize and contact the right patient who is deteriorating, but maybe group message the patients who are doing okay. I don't think of anything else, but I was going to open up to the floor if there's any questions from the floor about our deployment and what we've learned from kind of deploying on a scale.
Hi, my name's Liz Robb, and I think that's absolutely excellent. My next question is, have we got as far down the road as sharing patients then that need to come in and get operated on, or do they stay on the same list for the same trust?
Yeah, so that's an excellent question. So from this pathway, what we've been able to do is accommodate all of the patients who've required to have surgery urgently in their own trust. So you can see from the numbers have actually been relatively small. And just coming back to what Debs was saying, the number of times we've interacted with the patients has been surprisingly high, but the majority of the interactions have been reassuring patients that actually things are okay, or answering relatively straightforward questions. The number of patients that have had to have surgery has been relatively small. They've all been accommodated in their own hospital, and I foresee that being possible going forward. Having said that, during COVID, we didn't do that, and that patients were able to access other hospitals in a coordinated way to make sure they got the treatment as required. And I think we're now doing this in a joined-up way with the same protocols across the whole of London, that if something were to happen to initiate that, then for sure it would be possible, but it's not happened yet.
Hi. Thank you so much, first of all, for the incredible life-saving work you're doing across London. My question is, it seems like a lot of the decision-making was done at a departmental level. Do you see a future where this type of procurement decision would have to be made at an ICS level? And if so, how would that affect a project like this?
So, although the ICSs are like statutory organisations, the organisation itself isn't quite there yet to enable economy of scale procurement across an ICS as a whole. I mean, what we're seeing in London is network level collaboration and host organisations hosting services on behalf of other centres. So, in this case, I think the contract is held at Barts, right? Yeah, so the contract's held at Barts on behalf of the whole of London, and then there's a fairly complex recharging structure in place to ensure that the service is paid for. And I think certainly from a clinical network point of view, that will be more common than. I think the answer to the question is yes. Eventually, ICSs will procure on behalf of the organisations within it. How long is that going to take before it's a real thing, and will it ever be a real thing? I think is still is up for debate. Depends on the maturity of the ICS, I would say.
Yeah, and to that point as well, I said, having sat on our local ICS virtual ward committee, there's vast degrees of maturity of organisation that's been formed, and maturity of digital kind of understanding and what's within the ICSs. So I think it is very difficult at this stage. I see this maturing in the next 2 to 3 years with best of breed coming out. The vast majority of digital health solutions at present have come through kind of relationships as opposed to proper procurements. I think that's fair to say. But at scale, you're going to need a real collaboration between secondary care, primary care, in that continuum. And at the moment, I think the ICSs are the funding body, so that's where the money is. But I think it will be with collaboration with secondary care once the initial ask of kind of frailty, virtual wards, and respiratory expand, which it should do. The natural house for remote monitoring and is long-term conditions, patients like this, early discharge out of hospital, or preventative, or preventing a patient coming in.
Joe Steele, health tech advisor and investor. Clearly what you've achieved here is hugely impressive. How does this get known better across ICS's other areas of the UK, and what mechanisms are starting to be put in place to share all of this good work?
That's a really interesting question. Wish I knew.
I think authors probably need to invest in a better PR budget, would be my initial advice to the business itself. But I think the NHS as a whole probably needs to do better when it comes to sharing digital success stories like ours. I mean, we are in conversations about going through the award type process through the regional comms office and comms teams, which obviously gives a bit of notoriety over what's happened, and puts a stamp of approval on it from a kind of this is a good thing perspective. But I think it's a constitutional failure for us when it comes to sharing successes within the service more generally. There's some good work been done on the digital playbooks, nationally, which I think were a good idea, but how much were they used, I'm not too sure. I think they were good referenceability for organisations or ICSs that needed a bit of help. But certainly moving forward, something we need to pitch to the national team as to something to do better. So take that as a as a hint. Thank you.